and you can see the slide also, right? Okay. So today we'll be discussing on ptosis, lead tumor, entropion, and entropion. So starting with ptosis, it is an abnormally low position of upper eyelid or drooping of upper lid. So yesterday I told you that the normally upper eyelid covers about 2 mm of the cornea. So if it covers more than 2 mm of the cornea, then that is drooping of upper eyelid, which is known as ptosis. It can be congenital or acquired. So this is the picture showing ptosis of the right eye. So here we can see drooping of upper eyelid. And this acquired ptosis is of 4 types: neurogenic, myogenic, aponeurotic, and mechanical. Neurogenic ptosis is due to innervational defects such as third nerve and oculosympathetic palsy, that's Horner syndrome. Myogenic due to myopathy of levator muscles. Aponeurotic is defect in levator aponeurosis, and mechanical is gravitational effect of mass or scarring. So coming to neurogenic ptosis, it may be due to third nerve palsy, Horner syndrome, Marcus-Gunn jaw winking syndrome, third nerve misdirection. And myogenic may be due to myasthenia gravis, myotonic dystrophy, ocular myopathy, and simple congenital. Aponeurotic may be due to involutional, that is due to aging, post-operative after surgery. It may cause, like after cataract surgery also in some patients, aponeurotic ptosis may occur, but it's temporary. And mechanical may be due to tumors, dermatocalluses, edema, scarring of the upper eyelid. This is very important, that how to evaluate a case of ptosis. First, we have to rule out whether it is pseudotosis or ptosis. And this pseudotosis means false impression of ptosis. So causes of pseudotosis are lack of lid support and contralateral lid retraction. If there is contralateral lid retraction, then so this is the contralateral lid retraction, and so that this eye looks like ptosis, but it's not ptosis, it's pseudotosis. And ipsilateral hypertropia. If there is a hypertropia, then it looks like ptosis. And this is brotosis, where there's excessive eyebrow skin. Okay, and dermatocallusis. In case of aging, due to excessive laxity, there will be drooping of the lid, which is pseudotosis. So we have to first rule out the pseudotosis. Then we have to observe whether it is unilateral or bilateral. Then we have to look for function of orbicularis oculi muscles. We have to look for eyelid crease, whether eyelid crease is present or absent. Mostly in case of congenital ptosis, eyelid crease will be absent. And we have to check Bell's phenomenon, that is up and out rolling of eyeball during forceful closure of the eyelid. Then jaw winking phenomenon, that is Marcus-Gunn phenomenon. The stimulation of the trigeminal nerve by contraction of the pterygoid muscles of jaw results in the excitation of the branch of the oculomotor nerve that innervates the levator patribus superioris ipsilaterally on the same side of the face. So the patient will have rhythmic upward jerking of their upper eyelid. So while winking of the jaw, we can see in this picture there is ptosis of the right eye, and on winking of the jaw, there is no ptosis. So this is called as jaw winking phenomenon. And we have to measure the degree of ptosis to grade whether it is mild ptosis, moderate ptosis, or severe ptosis. So mild ptosis means if it covers 2 mm of the cornea, more than 2. And like we know that the upper eyelid normally covers 2 mm of the cornea. So after measuring the covering amount, we have to subtract by 2 mm. So if it comes 2 mm, then it is mild ptosis. If it's 3 mm, it is moderate ptosis. And if it's 4 mm or more, it is severe ptosis. So this This is the picture of the normal eyelid where the upper lid covers about 2 mm of the cornea. So if it covers like up to here, it is 2 mm of drooping, then it is mild ptosis. And this is 3 mm moderate. And if it covers the 4 mm or more, it is severe ptosis. And another important thing in evaluation of ptosis is MRD, which is known as marginal reflex distance. We have MRD1 and MRD2. So MRD1 is the distance between upper eyelid margin and corneal light reflex. So this distance from the upper eyelid to this corneal light reflex is MRD1. This is normally 4 to 5 mm. And MRD2 is the distance between lower eyelid, this lower eyelid up to corneal light reflex is MRD2, which is about 5 to 6 mm normally. So we have to measure this also. And the distance between upper eyelid to lower eyelid is levator palpable distance, palpable fissure distance. So MRD1 plus MRD2 is MRD3. And another is assessment of levator function. This is very important in ptosis evaluation because depending upon the levator function, the what kind of treatment that the patient need is decided. So this is very important, which is known as Berg's method. So here in this procedure, thumb is placed against the brow to obliterate the action of frontalis muscle. So the patient is asked to look down, and here the thumb is placed over the eyebrow to compress the action of frontalis muscles. Then the patient is asked to look upward, and we measure the distance in the scale. And if it's 15 mm, then that means it's normal levator function. If it's 12 mm or more than that, it's good. And if it's 5 to 11 mm, it's fair. And if it's 4 mm or less than that, that means that the levator function is very poor. And this is vertical fissure height. That is the distance between upper and lower eyelid margin. That is MRD3. MRD1 plus MRD2 is MRD3, which is vertical fissure height. So this is the height, and normally it is 7 to 10 mm in male and 8 to 12 mm in female. So if it's less than that, then that is ptosis, okay? And another is we have to evaluate upper eyelid crease. So we have to check for the eyelid crease. And the distance between the lid margin and lid crease in down gauge. In case of congenital ptosis, I've already told you that the upper eyelid crease will be absent. And if it's present, then normally it is 10 mm, and in female, it is 8 mm. So the distance from this upper eyelid margin to the lid crease has to be measured to evaluate the ptosis. And if it's high crease, then it suggests aponeurotic ptosis. And pretarsal, so the distance between lash line and skin fold in primary position of gaze has to be also measured. And other investigations like tensilon test, phenylephrine test is also done in case of ptosis. If myasthenia is suspected, then tensilon test is done. That in this tensilon test, what we do is we inject entropion. And if there's improvement of ptosis, then it means the patient has the cause of ptosis is due to myasthenia. And in case of phenylephrine test, it is done in case of Horner's syndrome. And the another thing is photographic record is also important for comparison to see whether the progression has been there or not. Now, simple congenital ptosis, it's due to developmental dystrophy of levator muscles. Occasionally, it is associated with weakness of superior rectus. And it may be unilateral or bilateral of varying severity. And in downgaze ptotic eyelid, slightly higher. So this is slightly higher. and frequent absence of upper eyelid crease. So in congenital ptosis, there's no eyelid crease. So there'll be absent of lid crease. And usually in case of congenital ptosis, levator function will be poor. And this is aponeurotic ptosis, which is caused due to weakness of levator aponeurosis. It may be due to involutional, postoperative, and blepharochalasis. So in case of aponeurotic ptosis, eyelid crease will be high and good levator function. In case of mild cases, and in case of severe, there will be absence of upper eyelid with deep sulcus. And mechanical ptosis means if there is like large tumor or severe lid edema, then it will cause drooping of the upper eyelid. So these are the causes of mechanical ptosis. Now coming to treatment, Fascinella cervic procedure is indicated in case of mild ptosis with good levator function. And levator resection is indicated for ptosis with levator function of at least 5 mm. Frontalis brow suspension is indicated in case of severe ptosis with poor levator function, which is 4 mm or less than that. And in also Marcus gun jaw winking syndrome, this is the treatment of choice. So you don't need the surgical steps in detail, but you should know at least the name of surgery that is done for ptosis, but you don't need the whole surgical steps, okay? Now coming to lid tumors. Benign lid tumors include squamous cell papilloma, basal cell papilloma, inverted follicular keratosis, actinic keratosis, keratocanthoma, melanocytic nevus, capillary hemangioma, pyogenic granuloma, xanthelasma, and neurofibroma. And malignant lid tumors include basal cell carcinoma, squamous cell carcinoma, Meibomian gland carcinoma, melanoma, Kaposi-sarcoma, Merkel cell carcinoma. Did anyone say something? Are you hearing me?
Yes, ma'am.
Oh, what happened?
Oh, no, ma'am. Ma'am.
Hey, okay, all right. So this basal cell carcinoma and squamous cell carcinoma are the important lead tumors. You should know these two tumors, okay? And others you should know the names of the tumors, but these two tumors you should know in details. Now, basal cell carcinoma, it is the most common human malignancy. It usually affects elderly. It is slow growing, locally invasive tumor. It does not spread to regional lymph nodes. 90% occur on head and neck, and it involves, and 10% involve eyelid. It accounts for 90% of eyelid malignancy. So it's common tumor of eyelid. What happened? It's also, please mute your mic, everyone, okay? It is also called as rodent ulcer, and it involves 70% of lower lid, 15% of medial canthus, 10% of upper lid, and 5% of lateral canthus. It is divided into 3 types: nodular, ulcerative, and sclerosing. Nodular basal cell carcinoma is of 2 types, early and advanced. So in this picture, in early type of nodular basal carcinoma, we can see shiny indurator nodule with surface vascularization. Whereas in case of advanced case, it destroys the large portion of the eyelid. That's why it is known as rodent ulcer, as it destroys the eyelid. And this is ulcerative type of carcinoma, where there's chronic ulceration, and here we can see raised roll edges and bleeding in case of advanced type. Sclerosing type in case of early, There is indurated plaque with loss of lashes, so there are absent of eyelashes. It may mimic chronic blepharitis. And this is advanced type. It's spread radially beneath normal epidermis. Margins are impossible to delineate. We can't differentiate the eyelid margin in this advanced type of carcinoma. And treatment is surgical excision, cryotherapy if it's untolerable to surgery, and radiotherapy is done for palliative treatment. Now, squamous cell carcinoma is less common, but it is more aggressive than basal cell carcinoma. It metastasizes to regional lymph nodes in 20% of cases. It accounts for 5 to 10% of eyelid malignancies. The most common site is lower eyelid and lid margin. Nodular, it's of two types, nodular and ulcerative. So this is the picture showing nodular type of squamous cell carcinoma, which is hard, hyperkeratotic nodules, and there is no surface vascularization as in case of basal cell carcinoma. It may develop crusting features. And this is ulcerative type, which has red base. Borders are sharply defined, indurated, and elevated. Treatment is same, surgical excision, radiotherapy. So this is mostly done by oncologist. So, and Meibomian gland carcinoma, it arises from the Meibomian gland in the tarsal plate. It presents as a nodule in upper eyelid, later destroys the Meibomian gland orifice. It metastasizes to regional lymph nodes. And treatment is surgical excision with biopsy. Malignant melanoma, it may develop de novo or from pre-existing melanotic nevus. It involves eyelid in form of superficial spreading malignant melanoma, lenticulomaligna melanoma, or nodular melanoma. Treatment is radical excision. Now the next topic is entropion. So this is the picture of entropion where there is inward rotation of the eyelid margin. So here we can see inward rolling of the lower lid margin. So it is of two types, congenital and acquired. In acquired, it is again of three types, involutional, cicatricial, and spastic. Congenital entropion is rare and it's associated with congenital epiblepharon. And in acquired, involutional means due to aging, cicatricial may be due to infectious or non-infectious. Trachoma is the most common cause of cicatricial entropion, and a non-infectious chemical injury is the common cause of cicatricial entropion. And spastic is due to ocular irritation. So this is the picture of involutional entropion, and it mostly occurs in elderly people. It mostly affects lower lid because upper lid has wider tarsus and it's more stable than the lower. That's why it is commonly occur in the lower eyelid. So this is the involutional entropion. And cicatricial means it may affect lower or upper eyelid because the most common cause for cicatricial entropion is trachoma. And this congenital entropion, there's absence of lower lid crease. When skin is pulled down, lid also pulls away from the globe. And it's very rare, not to be confused with epiblepharon. Pathogenesis, horizontal lid laxity, which is caused by stretching of the canthal tendons and tarsal plate. It is tested by snapback test. Here, the eyelid is pulled inferiorly. If the eyelid springs to its normal position without a blink, it means no lid laxity. And if it remains away from the eye for some time, it means there is lid laxity. Then the degree of lid laxity will be determined by the number of blinks required to bring the lid on contact to the eye. So we have to count the blink, number of blink. After how many blink that the lid comes back to its normal position, we have to count the number of blinks, which is known as snapback test. And another is weakness of lower lid retractors, which is tested by down gaze to see position of lower lid. And the another cause for entropion is overriding of preseptal to pretarsal orbicularis oculi muscles, tarsal plate atrophy, and atrophy of retrovalvular fat. So these five causes the entropion. So this is the picture showing back test. So here we can see the lead is pulled, and after removing the fingers, if it comes back to its normal position immediately, then that means there's no lead laxicity. And if it takes some time to come back to its position, then there is lead laxicity. And how much lead laxicity is there, we have to count the blink. So after how many blink it come back to its normal position, we have to look for that. Okay. So these are the pathogenesis of entropion. This is very important. I've told you earlier also, horizontal lead laxicity, canthal laxicity. So this is the picture showing overriding of preseptal orbicularis for pretarsal orbicularis, and weakness of lower lid retractors. And another is atrophy of fat, retrovalvular fat. These all leads to entropion. Now, clinical features. As the eyelashes are turned inward, it will cause irritation, discomfort, watering, and redness of the eye. And sign includes trichiasis. Trichiasis means inward turning of the eyelashes. And because of that, the eyelashes will touch the cornea, and it will lead to corneal punctate epithelial erosion, which leads to ulceration and pannus formation. So this is the entropion, which causes trichiasis, and the eyelashes are touching the cornea, leading to ulcer and pannus formation. So it is divided into three grades, 1, 2, and 3. Grade 1 means only posterior lid margin is involved. Grade 2 means turning of the lower lid up to intermarginal strip. And grade 3 means whole lid margin, including anterior border, is turned inward. And treatment for involutional, temporary, or medical treatment includes lubricating drops, lower eyelid taping, soft bandage contact lens to prevent the cornea, and botulism toxin injection. And surgical treatment includes, if there is no excess horizontal laxicity, then which procedure is done. If there is excess horizontal laxicity, Quicker's procedure is done. And in case of recurrent type of entropion, John procedure is the treatment of choice. So this is the picture showing the treatment for involutional entropion. This is transverse everting suture. This is a temporary surgical treatment for entropion. This is Weiss procedure, where there's shortening of the lower lid, and John's procedure for recurrent case. Cicatricial entropion is treated by contact bandage lens, and surgical treatment includes, if it's mild, then tarsal fracture with anterior rotation of the lid margin, and in case of severe, replace the scarred tarsus with graft. And in case of spastic entropion, taping of the lid is done, or eyelid everting suture is the treatment of choice. And in case of congenital entropion, Hall's procedure is done, that is tarsal fixation eyelid everting suture. Now the next topic is ectropion. Just opposite of entropion is ectropion. So in case of entropion, the eyelid margin is turned out from its normal opposition of the globe. So here we can see this eyelid margin is turned outward. It is of two types, congenital and acquired. Acquired is of 4 types, involutional, cicatricial, paralytic, and mechanical. It is graded as mild, moderate, and severe. In case of mild, lower punctum is everted. In moderate, tarsal conjunctiva is exposed. And in severe type, the whole palpebral conjunctiva and fornix are exposed. So this is the picture of severe type of ectropions. because we can see this palpable conjunctiva and fornix as well. So this is severe type of entropion. Okay, involutional, it affects lower lid of elderly patients. It may cause chronic conjunctival inflammation and thickening of the conjunctiva. As the conjunctiva is exposed, so it will lead to inflammation and thickening of conjunctiva. So pathogenesis is same: horizontal lid laxicity, medial canthal tendon laxicity, and lateral canthal tendon laxicity. Treatment. So this is a mild medial ectropion. Ectropion is present only in the medial side of the eyelid. In such condition, medial conjunctivoplasty is done. And in case of severe type of medial ectropion, lazy procedure is done. So this and if it's like extensive ectropion without marked excess skin, then horizontal lid shortening is done. And with marked excess skin, Kuhn-Siemowski procedure is done. So this is the common surgery that we do. If there is a marked excess, then this triangular shape of whole thickness eyelid is cut off and is sutured. A cicatricial ectropion is due to contracture of skin pulling lid away from the globe. It may be unilateral or bilateral depending on cause. Unilateral ectropion is due to traumatic scarring, and bilateral ectropion may be due to severe dermatitis or burn. So if there is scarring over the lower eyelid, then it will pull the eyelid, leading to cicatricial ectropion. So treatment depends upon the severity of the ectropion. In case of mild localized case, they are treated by excision of scar tissue combined with jetplasty. And in case of severe cases, it requires transposition flap or free skin graft. And this paralytic ectropion is caused by facial nerve palsy, which, if severe, may give rise to the following conditions. So if there is facial nerve palsy, there will be unable to close the eye, which is known as lag of thalamus. And if the patient is not able to close his eyes, then the cornea will be exposed, which leads to exposure keratopathy. So paralytic ectropion leads to lag of thalamus and exposure keratopathy. And epiphora, which is caused by combination of failure of lacrimal pump mechanism, malposition of inferior lacrimal puncta, and increase in tear production resulting from corneal exposure. So these paralytic ectropion leads to epiphora also because of the pump failure. Now, treatment of paralytic ectropion. Medical treatment includes lubricating drops, botulism toxin, which is given in levator muscles, and temporary tarsorrhaphy. This temporary tarsorrhaphy is to close the eyelid so that the cornea is not exposed. And the permanent treatment includes medial canthoplasty, lateral canthal sling, and gold weights. And the next is mechanical ectropion is mainly caused by the tumors. So treatment is treat the cause. So if the cause is the tumor, then we have to remove the tumor. Okay, thank you.